Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 303 of our pharmacotherapy series, which majors in chronic stable angina. The first question reads, J.A.P, a 62-year-old dairy farmer, is hospitalized for evaluation of chest pain. About 3 weeks before admission, he noted substernal chest pain brought on by lifting heavy objects or walking uphill. He describes a crushing or vis-like pain that never occurs at rest and is not associated with meals, emotional stress, or a particular time of day. When J.A.P stops working, the pain subsides in about 5 minutes. J.A.P's mother and brother died of a heart attack at ages 62 and 57, respectively. His father, who is alive at age 86, has survived 1 heart attack and 1 stroke. The family history, except for J.A.P, is negative for diabetes mellitus. J.A.P is 5 feet 10 inches tall and weighs 235 pounds. He drinks 2 or 3 beers a day and does not smoke or chew tobacco. J.A.P's other medical problems include a 10-year history of hypertension and diabetes mellitus for 4 years. Until 3 weeks ago, J.A.P could perform all his farm chores without difficulty, including heavy labor. He follows a no-added-salt diet, but consistently eats at fast food establishments, with his favorite meal consisting of 2 cheeseburgers and French fries. J.A.P's medication history reveals the following: lisinopril 10 mg once daily, metformin 500 mg twice daily, and hydrochlorothiazide 25 mg once daily. He rarely uses over-the-counter medications. He has an allergy to sulfamethoxazole. On admission to the cardiac ward, J.A.P appears his stated age and is in no apparent distress. Resting vital signs include supine BP, 145 systolic, 95 diastolic. During the last ambulatory visit it was 130 systolic, 85 diastolic. He has a regular pulse of 84 beats per minute. During his last ambulatory visit, it was 78 beats per minute. His respiratory rate is 12 breaths per minute. He has no peripheral edema or neck vein distension, and lung auscultation is within normal limits. Abdominal examination is unremarkable and he is alert and oriented ×3. Cardiac auscultation reveals a regular rate and rhythm with a normal S1 and S2, third or fourth heart sounds, and murmurs are not noted. A 12-lead ECG reveals normal sinus rhythm at a rate of 84 beats per minute without evidence of previous myocardial infarction. All intervals are within normal limits. His admitting laboratory values include the following: a hematocrit of 43.5%, a white blood cell (WBC) count of 5,000 per microliter, sodium levels of 140 milliequivalents per liter, potassium levels of 4.7 milliequivalents per liter, magnesium levels of 1.9 milliequivalents per liter, random blood glucose of 132 milligrams per deciliter, hemoglobin A1C of 7.4%, blood urea nitrogen of 27 milligrams per deciliter, Serum creatinine of 1.4 mg per deciliter. Urinary albumin-creatinine ratio of 27 mg per millimole. Chest radiograph is within normal limits. What signs and symptoms does J.A.P. exhibit that are consistent with the diagnosis of chronic stable angina? J.A.P.'s description of his chest pain includes several common characteristics of angina pectoris. The substernal location of J.A.P.'s chest pain is typical, although some patients describe pain radiating down the left arm or pain that is referred to the shoulder area or jaw. J.A.P.'s pain is described as crushing or vis-like in quality, which also is common. A fullness in the throat or jaw may occur simultaneously or in lieu of chest pain. In some cases, the patient may not consider these sensations as pain, describing them instead as a sense of pressure or heaviness. Many patients complain of shortness of breath. J.A.P.'s symptoms are related to exercise and exertion, both known precipitating factors of angina. Most episodes of exertional angina last several minutes in duration and are relieved with rest. Because J.A.P. has never sought medical attention for his chest pain, his response to nitroglycerin cannot be determined. After getting a detailed description of J.A.P.'s symptoms, his physician can characterize his chest pain and make a global assessment. Initially, the chest pain should be classified as either typical angina, atypical angina, or non-cardiac chest pain. Furthermore, angina should also be classified as either stable or unstable. This distinction is important because it indicates whether his short-term risk of an acute coronary event could be life-threatening. Attempts to categorize J.A.P.'s anginal symptoms on an objective measurement scale, e.g., Canadian Cardiovascular Society grading scale, can be misleading. For example, a sedentary 65-year-old patient's Class II symptoms may be tolerable, but the same symptoms could significantly disable an active 50-year-old patient. J.A.P.'s chest pain is of a quality and duration characteristic of angina, provoked by exertion, and relieved by rest. Therefore, J.A.P.'s constellation of symptoms can be classified as typical chest pain. J.A.P.'s symptoms do not occur at rest, however, they should be classified as stable angina. The next question reads, assess J.A.P.'s physical examination. What signs and symptoms are relevant to the angina? The physical examination typically provides little information about the presence of coronary artery disease. The most useful findings pertain to the cardiovascular system, where heart rate and BP can be increased during an acute anginal episode. J.A.P.'s physical examination is characteristic of a man of his age with angina. He is obese and hypertensive, but his cardiac examination is normal. The presence of murmurs would have required further workup. The absence of a third heart sound suggests that the left ventricle may be functioning normally. The absence of a fourth heart sound in J.A.P. is indicative of a low probability of cardiac end organ damage resulting from systemic hypertension. His chest radiograph, which is normal, does not present evidence of other complications commonly associated with myocardial ischemia, e.g., enlarged heart, or heart failure. J.A.P.'s physical examination should also evaluate the possibility of the presence of atherosclerosis in other major vascular beds, that is, peripheral vascular disease, cerebrovascular disease, or abdominal aortic aneurysm. The presence of xanthomas would suggest severe hypercholesterolemia, but these were not noted in J.A.P. The next question reads, what other objective diagnostic procedures are helpful to confirm coronary artery disease and angina in J.A.P.? A 12-lead ECG indicates there is no ongoing ischemia at this time. As such, it does not help confirm the diagnosis of coronary artery disease. An echocardiogram could be used to better assess cardiac structure and function, including ruling out other potential causes for myocardial ischemia such as valvular dysfunction or pericardial disease, but would not definitively confirm the presence of coronary artery disease. Electron beam computed tomography or CCTA could be used to detect the presence of coronary atherosclerosis, but in J.A.P. would not offer vital prognostic information available with other testing modalities. Given J.A.P.'s current lifestyle and activity level, he would likely be able to tolerate exercise treadmill testing. Treadmill testing would be an appropriate initial diagnostic modality in J.A.P. due to its non-invasive nature, reliability with established protocols, as well as the ability to offer prognostic information regarding the risk of myocardial infarction and death for J.A.P. Therefore stress testing, in this case with exercise treadmill versus pharmacologic means, is an excellent initial diagnostic modality to use in J.A.P. The next question reads, should J.A.P. undergo cardiac catheterization? How will the results of this invasive procedure influence future therapy? Coronary catheterization and angiography is the best test for the definitive diagnosis of coronary artery disease. In addition, angiography is the most accurate means of identifying less common causes of chronic stable angina, such as coronary artery spasm. Although angiography is effective at identifying flow-limiting atherosclerotic plaques in the coronary vasculature, it cannot provide information on whether those lesions are causing clinical symptoms. Stress testing is often a more appropriate initial modality to first characterize the myocardial ischemia that takes place with exertion. Patients with significant ischemia via stress testing should then undergo cardiac catheterization to determine the nature and extent of disease. The results of angiography will be useful in determining the risk of death or myocardial infarction in J.A.P. and, subsequently, the course of needed treatment. For example, patients who have a significant stenosis in the left main coronary artery are at high risk of death and should undergo CABG. The next question reads, after having a positive treadmill stress test and undergoing subsequent cardiac catheterization, J.A.P. is found to have two-vessel coronary artery disease with obstructive lesions of 55% and 70% in the right coronary artery, abbreviated as RCA, and circumflex arteries, respectively. The left anterior descending coronary artery is not involved. What is his prognosis? The prognosis of patients with stable angina is variable and dependent on the presence of other factors and comorbid conditions. The extent of coronary artery disease, quantification of ventricular function, the response to stress testing, as well as the initial clinical evaluation all help to provide an estimate of risk in a given patient. Developing a level of risk for a particular patient helps determine the appropriate treatment strategy. J.A.P.'s history and physical examination suggest he does not have heart failure. Poor left ventricular function would be an ominous concurrent finding. J.A.P. also does not have three-vessel disease or blockage of the left anterior descending artery. J.A.P. does have type 2 diabetes mellitus, which elevates his risk for future cardiovascular events. The absence of other major comorbid conditions, myocardial dysfunction, along with the current extent of coronary artery disease indicates that J.A.P.'s prognosis at this time is favorable provided he initiate appropriate treatment strategies demonstrated to reduce morbidity and mortality in patients with coronary artery disease. The next question reads, how should J.A.P. be managed at this time? Should he undergo revascularization with percutaneous coronary intervention or CABG, or be managed medically? As discussed previously, goals for managing coronary artery disease and angina in J.A.P. include relief of symptoms and reduction of myocardial ischemia to improve quality of life, as well as prevention of major complications of coronary artery disease such as acute myocardial infarction and death. Depending on the patient, both goals may be accomplished through surgical revascularization, medical management, or both. Regardless of the treatment strategy chosen to relieve ischemic symptoms, therapies that prevent death, that is vasculoprotective agents, should receive priority. Presently, CABG is not the best option for J.A.P. because the usual indications for surgical therapy include presence of left main coronary artery disease, presence of three-vessel disease, especially if left ventricular function is impaired, or ineffectiveness of medical therapy. However, revascularization with percutaneous coronary intervention is a potential option along with medical management alone. Although percutaneous coronary intervention would offer no mortality advantage over medical therapy at this time, it has been shown to decrease the incidence of recurrent symptoms in the short term, that is 1 year. If J.A.P. can implement aggressive lifestyle modifications and control of risk factors, progression of coronary artery disease and control of ischemic symptoms will be similar to percutaneous coronary intervention within a 5-year time frame. Both strategies, including the pros and cons of percutaneous coronary intervention or medical management alone, should be offered to J.A.P. so that an informed decision can be made in accord with his wishes. Overall, J.A.P. will probably do well with medical therapy. His life expectancy depends on progression of the disease and development of other complications of coronary heart disease, that is heart failure, myocardial infarction, or sudden cardiac death. The next question reads, what independent risk factors for coronary artery disease are present in J.A.P.? Which of these may be altered? The first step in the treatment of any patient with chronic stable angina or coronary artery disease should be the modification of any existing risk factors and the adoption of a healthy lifestyle. By addressing the underlying circumstances, which likely led to the development of coronary artery disease, a significant impact can be made at halting the progression of the disease and preventing complications of coronary artery disease. In addition to specific risk factor goals, attention should be paid to evidence that favors specific drug therapies that have evidence supporting reductions in morbidity and mortality. Examples would include the use of HMG coenzyme A reductase inhibitors in the treatment of hyperlipidemia, as well as the use of ACE inhibitors for the treatment of hypertension. J.A.P. has several risk factors for coronary artery disease, some of which cannot be altered, such as middle age, male sex, and a strong family history of coronary artery disease. Risk factors, such as hypertension, obesity, hypercholesterolemia, smoking, and possibly stress, can potentially be modified to decrease the likelihood of adverse sequelae for J.A.P. His hypertension should be controlled and statin therapy should be initiated. A fasting hemoglobin A1C should be drawn with a goal of less than 7%. Dietary modification and weight reduction for J.A.P. are mandatory, because they positively influence several risk factors. J.A.P., however, does not smoke cigarettes, which would significantly increase his cardiovascular risk. J.A.P.'s active lifestyle may influence his prognosis favorably. The next question reads, are there any dietary patterns that J.A.P. can adopt that have demonstrated reductions in cardiovascular endpoints? Although the positive effects of lifestyle modifications on cardiovascular risk factors are well recognized, the effect of specific lifestyle interventions on reducing hard cardiovascular endpoints can be underappreciated. The adoption of a healthy dietary pattern is one such example. Randomized controlled trials have demonstrated that the adoption of the Mediterranean diet, that is, diets emphasizing whole grains, fruit, vegetables, nuts and legumes, moderate dairy intake, moderate amounts of lean protein, and polyunsaturated fats, reduced the relative risk of myocardial infarction or cardiac death by 50% to 73% as compared to a diet similar in composition to the AHA Step 1 diet. It is important to note that in one of these studies, the Lyon Diet Heart Study, the improvements in cardiovascular morbidity and mortality occurred without significant changes in the lipid profiles of study subjects. One trial found the Mediterranean diet supplemented with either nuts or olive oil reduced cardiovascular events in patients at high risk of cardiovascular disease when compared to a low-fat diet. Several additional trials demonstrated that patients with a history of myocardial infarction who increased their intake of either fatty fish or ingested omega-3 fatty acid fish oil supplements also had reductions in cardiovascular death and myocardial infarction as compared to control patients without dietary intervention. Lastly, epidemiologic studies have confirmed the results from randomized controlled trials showing that adherence to a Mediterranean diet significantly reduces cardiovascular morbidity and mortality. A Mediterranean diet reduces systemic inflammation as measured by C-reactive protein, reduces the incidence of insulin resistance, and improves endothelial function. Although a great deal of attention has been directed at the increased intake of omega-3 polyunsaturated acids, such as eicosapentaenoic acid and docosahexaenoic acid derived from fish or alpha-linoleic acid derived from plants being responsible for the observed benefits in each of these trials, multiple dietary alterations were likely in play. The results should be interpreted as the result of the adoption of a healthy dietary pattern. So there you have it, our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 304.